So next we have our next speaker, Dr. Bhaskar Pal. He's a very well-known speaker. He's a senior consultant gynecologist at Apollo Multi-Speciality Hospital, Kolkata, and chair of Endoscopy Committee, CEFOG, chair of AICC RCOG, immediate past president IAGE, and FOXY representative to CEFOG, chair organizing committee AICOG in Kolkata last year, and past president Bengal Obstetric and Gynec Society.
That's enough, madam.
Okay, but it is.
Thank you,
People
madam.
should know whom they are listening to.
No, thank you.
Yeah.
I bring you greetings from Kolkata, and at the outset, I have a disclaimer. I think I'm one of the maybe exceptions in this conference who doesn't do IVF. Okay, I don't do infertility. I'm an endoscopic surgeon, and that is why I am here to speak on fibroids and infertility. I think it is great if somebody not from infertility speaks on which fibroids need to be treated for infertility, because if you have a hammer in your hand, everything in the world looks like a nail. So it is better to put that in perspective. So what I'm going to talk about, fibroids and infertility, fibroids and IUI, and fibroids and IVF, and each of these in the perspective of submucous fibroid, intramural fibroid, and subserous fibroid. Now, we've all grown up reading Jeff Coates' textbook, and one of the chapters, famous chapters of Jeff Coates' textbook was fibroids. And when we were undergraduate students many years back, almost 50 years back, at that point of time, favorite questions of examiners in Viva were, what are the effects of fibroid on pregnancy? What are the effects of pregnancy on fibroid? We moved away from that. Means at the present moment, academics has moved away from copying from one textbook to the next edition of the textbooks and carefully looking at what evidence do we have to say that what we say. But on the whole, it does appear that women with fibroids have decreased fertility. What we also think that it depends on the size of the fibroid, the number of the fibroids, and the location of the fibroids. Now, why does it happen? There are plenty of theories, and we really, when we have plenty of theories, which means we really do not know what causes the problem. Now, what we know is blood flow to fibroids is less than compared to the adjacent to healthy myometrium. And also, we know that the blood flow to the uterine arteries is different in women who have fibroids compared to women who do not have fibroids. Also, if there is a fibroid in the endometrium or just under the endometrium, there is endometrial inflammation and altered local hormonal environment which may impede implantation. There is also altered uterine contractility that interferes with the sperm or embryo migration. But what we do know from evidence is that the presence of fibroids, regardless of their location, significantly decreases both implantation rates and clinical pregnancy rates. If you look at that, more or less, there's an 18% decrease in implantation rate. There is approximately a 15% decrease in pregnancy rate, and both the confidence intervals are well within statistical significance. But what we do not know, what is the impact of fibroid number and fibroid size on the fertility. But reproductive success does seem to be related to the location of the fibroid. And all of us are familiar with this FIGO classification of fibroids, when type 0 is like a fibroid polyp, type 1 is a submucous fibroid where more than 50% is in the cavity, type 2 is one which is submucous but less than 50% in the cavity. Type 2 is partly myometrial, but 3, 4, and 5 are completely intramural fibroids, whereas 5, 6, and 7 are essentially subserous fibroids. 5 is when it is partly myometrial, intramural, and partly subserous. Now, with this, what we know is that we need to see what is the cavity like. Is there a fibroid of type 0, type 1, or type 2? And how should we assess the cavity? The best way to assess a cavity is to screen women with a transvaginal sonography, and then if we have a doubt, to do a hysteroscopy. The other option we can do is a hysterosonography. HSG simply is not adequate. A filling defect in HSG does not mean anything. So essentially, we should start off with a TVS and back it up with a hysterosonography or with a hysteroscopy. What we do know that subserosal fibroid do not have any impact on fertility. What we also do know is submucous fibroids do have an impact on fertility as well as on implantation, and uniformly they have a negative impact on implantation rate, clinical pregnancy rate, miscarriage rate, live birth rate, ongoing pregnancy rate. Although the studies are few and small, all the controversy comes with intramural fibroids, which is type 2 to type 5 fibroids. Now, this is a Cochrane review of surgical treatment for fibroid for infertility, and this is updated in 2020, and it also comes to the conclusion that we do not have enough evidence to make any recommendation how they should be treated. So we need to go back to individual studies based on which this systematic review was based. Now, SOGC says in women we'll start off with when somebody presents with subfertility and has fibroids. And then we'll move on to what is the role of myomectomy before IUI, role of myomectomy before IVF. Now, in women with otherwise unexplained fertility, submucosal fibroid should be removed in order to improve conception and pregnancy rates. And subserosal fibroid should not be removed. This is a SOGC guideline, which is from 2015. It is supposed to be updated this year. And they also go on to say that there is fair evidence to recommend against myomectomy in women with intramural fibroids when there is a hysteroscopically confirmed intact endometrium and otherwise unexplained infertility, regardless of the size of the fibroids. And if the patient has no other options, which means unexplained infertility, everything has been exhausted, then you should counsel the women regarding the benefits of myomectomy vis-a-vis the risks, and management of intramural fibroid should be individualized. So even in our undergraduate days, we used to study that you should offer a myomectomy with infertility when you ruled out all other causes and the patient can't get pregnant. And I'm talking from pre-IVF days. So if somebody presents with infertility and has a submucous fibroid, it should be removed. If somebody has a subserous fibroid, should not be touched. If somebody has an intramural fibroid and all other causes are excluded, all other options are excluded, then we can consider myomectomy on an individual basis. What about doing an IUI? Now, I will not go back into submucous fibroid. Submucous fibroid in any woman with subfertility, in any woman with miscarriage, has to be resected. That goes for type 0 and type 1 fibroids. Type 2, a little bit contentious, come to that in a moment. Now, myomectomy prior to IUI for unexplained infertility, there is good studies to compare women who've got a non-cavity distorting fibroid versus no fibroid. And doing a myomectomy prior to IUI makes no difference to the clinical pregnancy rate and the live birth rate. So we should not offer myomectomy before IUI in a woman who has a non-cavity distorting fibroids. Now, this is the most controversial part, which is intramural fibroid and IVF. And I will look at all the data, but we need to understand that most of these data come from retrospective studies, some from controlled trials, but there are very few randomized controlled trials. And research has essentially been limited to retrospective cohort studies or case control studies fraught with intrinsic biases, confounding and clinical heterogeneity, and no evidence-based recommendations on clinical management can be made to improve reproductive outcomes. This is a review published in the British Journal in 2017. The biggest challenge is when a woman comes with a long-standing fertility and you sit down to discuss with her vis-a-vis a myomectomy versus doing nothing, most of these women would rather catch on to anything that they can catch on for hope and opt out of for that. So ethically, it becomes very difficult to randomize women to no intervention. Now, the theory is that with intramural fibroid, one school believes that there is a lower implantation rate and lower clinical pregnancy rates. The other group believes that it makes no difference in live birth rate or ongoing pregnancy rate. Now, if we look at the earlier studies of the 2004 study published in Fertility Sterility, which looked at 245 women, and they showed that there was a lower pregnancy rate after IVF ICSI if there's an intramural or subserous fibroid which is more than 4 centimeters. Lower pregnancy rates, but the live birth rates were similar. So it didn't make a difference to live birth rate. In 2006, there is a comparative study which looked at 61 cases of myomectomy and 444 controls, and they showed that if you had a single intramural fibroid which was less than 5 centimeters, then you have similar implantation rate and clinical pregnancy rate whether you do a myomectomy or not. So there was no benefit of doing a myomectomy in fibroids less than 5 centimeters. Now, this is a controlled trial of myomectomy prior to IVF, which was published in 2004, had around 170 women. And these women had at least one intramural or subserous fibroid of more than 5 centimeters. And they showed that if you did a myomectomy, the pregnancy rate was doubled at IVF compared to if you did the IVF without a myomectomy. Now, if you look at some of the more recent studies, in 2011, this prospective study of 119 non-cavity distorting fibroids of less than 5 centimeter size, and they showed there's no relation between clinical outcome and number or size of the fibroids. And in 2014, a retrospective study of around 250 women, and this is showed that if you had a non-cavity distorting fibroid which was more than 2.85 centimeters, then it significantly decreases the live birth rate after IVF. So this is one of the first studies which showed a very contradictory report. Till then, most studies showed that below 5 centimeter fibroid, there is absolutely no benefit of doing a myomectomy. Above 5 centimeters, some studies showed that there is a benefit in terms of both implantation rate and clinical pregnancy rate and live birth rate, but some studies could not show the benefit in live birth rate. This is the first study of 250 women which showed 2.85 centimeters seems to be the cutoff where there is a problem. And again, 2006, much earlier, there was a study which showed that even small fibroid reduced the pregnancy rate after IVF and ICSI by 40% and the live birth rate by 45%. Now, one of the biggest studies came of a meta-analysis of more than 6,000 IVF cycles, and this is from Sunkara, which showed that with pre-IVF myomectomy, the live birth rate was much higher. It's around 20%, 21% higher if you do a myomectomy. Now, this is one of the more recent studies, a retrospective matched single center cohort study of around 160 women. And this is for women with non-cavity distorting fibroids undergoing IVF compared to controls. And they showed that there is a lower live birth rate with a single fibroid more than 3 centimeters, or if the patient had 2 or more fibroids. So essentially, if you look at all the data, the controversy seems to be hanging around if there is a single fibroid between 3 to 5 centimeters. If you have a patient with infertility and you're going for any infertility treatment, you do not remove a non-cavity distorting fibroid. If you're doing an IUI, you do not remove a non-cavity distorting fibroid. If you do an IVF and there is a single fibroid which is more than 5 centimeter size, or if there are multiple fibroids, you should remove them. If you have a single fibroid which is less than 3 centimeter size, you should not remove them. The controversy essentially, what should you do between 3 to 5? Because the larger studies seem to indicate that 3 centimeter is where you get the benefit of doing that. Now, if you are doing a myomectomy, what kind of myomectomy you should be doing? If you have a type 0 or a type 1 fibroid, you should always do a hysteroscopic myomectomy. But there are 2 things that we need to remember. Hysteroscopic surgery kills more women than laparoscopic surgery. And essentially, it is because of the fluid absorption causing TCRE syndrome. Yes, it is less with bipolar energy, but it is not absent with bipolar energy. When you are resecting a fibroid and somebody says your deficit is 1500 and you think, well, you just have a little bit fibroid to go, it is very tempting to go ahead and continue the procedure, but no. At 1000, you should be looking at deficit of 1000 ml, you should be looking at stopping your surgery. By 1500, you must stop your surgery. And there's no question of doing a hysteroscopic surgery unless you have a proper fluid calculation system. The other options are that if it is a large fibroid, you can counsel the woman for a 2-stage procedure. If it's a large fibroid, large submucous fibroid, more than 5 centimeters with type 1, many of us would opt to do a laparoscopic myomectomy rather than a hysteroscopic myomectomy. And the other option is to give in GnRH analogs because it can shrink the size, but you lose time, and also it decreases the vascularity of the fibroid and causes less fluid absorption. For type 3 to type fibroids is always laparoscopic. I've written open, but unfortunately, in this day and age, your default mode is if somebody has to undergo a laparotomy, the question is, why not a laparoscopy? So when we do a laparoscopy, we need to be very careful about hemostasis, because indiscriminate use of energy source is what will weaken the myometrium and cause problems in pregnancy. We need to do proper suturing and not leave dead space around, because that is again what is going to cause poor healing and a weak myometrium. And we also know that a myomectomy in any form, it generates adhesions, that we need to use methods to prevent adhesions. And lastly, we'll talk of open. Now, what do we do with type 2 fibroids? Now, in type 2 fibroids are one when there are less than 50% inside the cavity. In expert hands, they can go for a hysteroscopic myomectomy, because they can get into the capsule and resect it. But otherwise, if somebody is not a master in hysteroscopic surgeries, type 2s are better operated by laparoscopy. Does open surgery has any disadvantage to minimal access myomectomy? Unfortunately, there are 9 trials with around 800 women. And as you know, Cochrane database doesn't tell you what is to be done. It just says whether there's a robust evidence to do that. And it says it can prove that there is less pain, shorter hospital stay, and less fever, but it cannot tell us whether in terms of pregnancy outcome, one is better than the other. But common sense says that laparoscopy follows more microsurgical principles, so it should be better in terms of at least prevention of adhesions, provided you can suture as well as you do in an open myomectomy. Is there any role of medical management? The answer is we do not know at the present moment. Current medical therapy for fibroids is associated with suppression of ovulation, reduction of estrogen production, or disruption of target action of estrogen or progesterone at the receptor level. It has the potential to interfere with endometrial development and implantation. So there is no role of medical therapy as standalone treatment for fibroids in the infertile population at the present moment. So take-home messages: cavity distorting fibroids, remove them. Not even before IUI. If they have infertility or they have a miscarriage, remove cavity distorting fibroids, and surely remove them before IUR or IVF. If it's a subserous fibroid, please do not touch it. If it is an intramural non-cavity distorting fibroid, do not remove prior to IUI. If it is more than 5 centimeters, remove it before IVF. If it is less than 3 centimeters, do not remove it before IVF. If it is between 3 to 5 centimeters, then you need to individualize and counsel. But if they have a failed IVF with a fibroid between 3 to 5 centimeters, is either there is a failed IVF or there is a miscarriage, that is when we should offer them myomectomy and then go ahead. So a trial IVF cycle to see what happens. So I think that is what is the situation. Less than 3, don't touch. More than 5, operate. Multiple fibroids, operate. 3 to 5, counsel them. Good ovarian reserve, do 1 trial IVF cycle, fails or the patient has miscarriage, offer them myomectomy. I think I'm done. Thank you very much. And I don't know whether this is an appropriate forum. I would seek your blessings and support for offering myself as a candidate for the Foxy President election later this year. Thank you very much. I'm happy to take questions.
Thank you, Dr. Bhaskar, for elaborating the management options for the fibroids. We all understand that in spite of their benign nature, once the patient comes with infertility and perchance a myoma is seen on ultrasound, every gynecologist gets into a dilemma what to tell the patient, whether to remove or not to remove. It's always a confusion in our mind. And Dr. Bhaskar has very efficiently and strongly explained to you the recommendations, and I completely agree with what he has told you, because practically we are doing the same. So kindly keep this in mind, and there should be no confusion. I think she has a question for you.
Thank you so much, sir, for the elaborate talk. So I would like to ask you, sir, since there is a controversy when there is a fibroid between 3 to 5 centimeter intramural, sir, I would like to ask you whether you take the decision based on the type also. If there is a type 3 fibroid, it is said that even if it is 3 to 4, then we have to remove it.
I think if it's a type 2 fibroid, I would always remove it.
Type 3, sir.
If it's type 3 to 5, no, it goes by the same principle.
Okay, so
It goes by the same principle. So if type 3 to 5, the patient has got a poor ovarian reserve, I might not want to waste time. So I might want to, then the question comes whether we should do a trial IVF cycle, or my benefit is that, as I said, that I don't do infertility. So I always take a infertility specialist's opinion and then decide means in conjunction how we should go forward. But usually our way forward to do a trial cycle of IVF in a type 3, if it is less than 5 centimeters, and if it is between 3 to 5, and if the IVF cycle fails or the patient has a miscarriage, then offer her a myometry.
okay, thank you, sir. But it is said that if it is a type 3 fibroid, then it may decrease the endometrial receptivity. So,
Yeah, that is what I was trying to say. Means the problem is that it is a question of a type 3 fibroid is a non-cavity distorting fibroid.
exactly. sir.
Type 1 and 2 are cavity distorting fibroids. And if you look at non-cavity distorting fibroids, essentially if it is less than 3 centimeters, there's no difference in IVF outcome. So 3 to 5 is what is the question.
Okay, thank you so much, sir.
See, for your question, when we are practicing infertility and we are also doing laparoscopic surgeries, it's very important to counsel the patient because fibroids are mostly multiple and you can miss a small myoma. And if you suggest surgery for a 3 to 5 centimeter intramural, maybe she does not conceive even after the surgery and the other myoma starts growing. So it's very important to counsel the patient that what she is going to get after the surgery, and you can practice IVF without removing also the trial IVF. And if she fails to conceive, then maybe you have a reason to conduct surgery.
See, the
Yeah, I
other
think that's
issue
a good
is
way
that
to
it
move
is
ahead.
very, very difficult to differentiate between a type 3 and a type 4 if it's a small fibroid. As a fibroid grows, everything becomes like a 3 or a 4. And the second problem is that we need to counsel that every time we do a myomectomy, she needs to wait for 6 months
Again,
because we need to give the myometrium a chance to heal.
thank you so much, sir.
I think. Please take a
The
mic.
evidence, as we look at the evidence, that if it is more than 2.85 is the cutoff that they've given. So any fibroid between above 3 centimeter intramural with a previous IVF failure should be removed.
Should be removed.
Thank you, Dr. Paul, for your very nice talk. And as an IVF expert, I feel in that situation, cavity distorting fibroids, what to do, the size, etc. I think currently we have a wonderful vitrification technology. Take the oocytes in 1 or 2, 3 cycles, fertilize them, store them, and then do whatever surgery you want with the expert like Dr. Paul. You do the surgery hysteroscopically and so on. And then after you have attained your right time, you transfer the embryo. Because we know now mathematically that nearly 10 to 12 good embryos, 10 good cleaving or maybe 8 blastocysts is going to guarantee a pregnancy in most of the patients who are not really refractory. So we have a time now to plan for surgery in case of a fibroid, considering the low responders or higher age group. Thank you.
Yeah, at any time with the normal ovarian reserve in young patient with the fibroids where surgery is indicated, but the patient is not willing for the surgery, at any time will you recommend interventional radiology, embolization
No.
for the
Definitely.
patient who
You
want
should-
future fertility?
No. If the patient wants future fertility,
Yes.
I will never recommend an uterine artery embolization or a MR guided ultrasound therapy. There are two problems with uterine artery embolization and MR guided focused ultrasound therapy. Number one, the reintervention rate is very, very high. If you look at MR guided focused ultrasound, the reintervention rate is close to 50% within 2 years. And if you look at uterine artery embolization, then it is very high if you look at a 5-year data. That's number one. Number two, uterine artery embolization, there is a theoretical risk of that patient ending up in the next pregnancy in a miscarriage or an FGR. But this is a theoretical risk. Of all the pregnancies that had happened, it's around 30, 40 odd pregnancies that have happened after uterine artery embolization. There is no evidence as of now, the numbers are small, to suggest that FGR is more frequent. But theoretically, because you are interfering with the blood supply to the uterus, you will not offer it to women who are desirous of fertility.
Yeah, very recently we did one embolization. The patient was not at all willing for the surgery, and she had 6 years of infertility. And after 3 months, she conceived, and
Yeah,
she's
as I
carrying.
said, that there are
Yeah.
the pregnancies that have happened after uterine artery embolization are mostly accidental and not planned, and most
No.
of them do not show an increased evidence of FGR. I have worked in one of the largest centers which used to do uterine artery embolization in UK at St. George's Hospital, and seeing the results, I'm not a fan of it.
Okay. Thanks.
So when you have a type 3 or 4 fibroid, 3 to 4 centimeters, but in the lower cavity, it doesn't distort the cavity. What would you suggest in those cases? A lower,
Same
lower.
story. Same story. If the patient is trying to conceive normally, do not interfere. If you are planning to do an IUI, do not interfere. If you are planning to do an IVF, it is more than 5 centimeters, remove. If it is less than 3 centimeters, don't do anything. If it's between 3 to 5, give a trial IVF. If it fails or patient has a miscarriage, remove it.
But if the patient doesn't have that many embryos, then do we do
So
a
if it's a poor ovarian reserve, I think the best option to do is, as Dr. Ghazasida suggested, that if you send the patient first for a stimulation, do the embryos, keep the embryos, and then go for a surgery.
Okay.
So that the 6 months that you're waiting in a patient with a borderline ovarian reserve, it doesn't go down further.
Okay.
So somebody with a young patient, normal ovarian reserve, I will not take the route as Sudarshana said, but somebody who's elder with a compromised ovarian reserve, given the fact that I might even need to open the cavity, in which case I will ask her to wait for 12 months before she gets pregnant. I think I need to get the eggs out before I do the surgery.
Okay, thank you.
I was just wondering, do you do office hysteroscopies for diagnosis before?
There are very few people who do office hysteroscopies. They do, and people are doing office hysteroscopic surgeries also. But there are two problems of office hysteroscopy. Number one, you're from UK, isn't it?
I'm from Denmark.
You are from Denmark. Okay. Indian patients have a little bit problems with tolerating local anesthesia. They're more intolerant of local anesthesia compared to the Western population. This
Can
is
be done without anesthesia.
No, I said without anesthesia versus anesthesia. That's one. Second problem is, as opposed to Denmark or most of the Europe, most of our healthcare is paid by the patient. And if I have to run an office hysteroscopy service, I have to have a 5 millimeter scope. I have to have a 2.8 millimeter scope. Who's going to pay for it? The patient. And that is why most people, unless those who have huge volume hysteroscopy, do not run an office hysteroscopy service. But yes, people do run.
So, but in fact, it'll be financially better for the patient if the patient is not, admitted, and it's a cheaper thing in the bigger run for the patient herself.
We do, for example, we do a lot of hysterosonographies. Lot of hysterosonographies to decide which patient to take up for hysteroscopy, because we do not have an outpatient hysteroscopy service. We do the hysterosonography to decide which patient to take up for surgery.
Okay. In my practice, we do a lot of office
Absolutely.
hysteroscopies.
As I said, that when we were in
so they just
UK,
walk in and out. Yeah.
we used to do a lot of office hysteroscopies, and we to run an outpatient AUB clinics where we'll do a hysteroscopy, endometrial biopsy, everything.
Thank you.
So one more question. Do fibroids increase the risk of missed abortions also?
Yeah, the fibroids definitely increase the risk of miscarriage, especially if it is a type 1 fibroid or a type 2 fibroid.
So,
Because-
sir, not type 1 or type 2. If it is a 5 centimeter intramural, not distorting the cavity, or if it is a subserosal.
Actually not. If it's a single fibroid, the answer is no. If it is multiple fibroids, if the patient has multiple fibroids, and if they are all type 3 or type 4, you will have some sort of cavity distortion. This is not coming into the cavity. It's a larger cavity, and all these problems occur. So multiple fibroids need to be treated differently, but a single intramural 5 centimeter fibroid with a miscarriage, no, I will not remove the fibroid. I think that's a very strict take-home message. Intramural fibroids do not cause subfertility, do not cause miscarriages.
Thank you, sir.
Good morning, sir. I'm from Chennai. My question is, we were debating on, whether to do surgery 3 to 5 centimeters, embolization and all that. Is there a role for using 25 milligrams mifepristone 2 to 3 months before ART?
Definitely. I don't think that we have any data on that. There were groups looking at ulipristal acetate before IVF, and nothing has been published. So I guess that it is not favorable. And this is 5 years back when people were trying to use ulipristal acetate. So either the results are not favorable, or because in between Europe went into the problem with ulipristal, and that is why at the present moment in Europe, ulipristal is very controlled, which is a shame. It's a wonderful drug. And but I do not think we have any data. Mifepristone, only data we have is essentially on bleeding control. The data on even volume reduction for mifepristone is contradictory.
Okay.
Means what happens if it's a type 0 fibroid and the patient doesn't have AUB, and this patient is not planning a pregnancy for say 2 to 3 years, maybe then you can give her ulipristal acetate 2 cycles to make that type 2 into a type 3 and wait what happens.
So, but not after freezing the embryos and prior to embryo transfer. Is there a role
it's
for
too much of a waste,
trying?
as I said, that all the medical management is essentially they not only cause inhibition of ovulation, which is not a problem if you've taken the eggs out, they also interfere with the endometrium.
Okay.
Both mifepristone as well as ulipristal, they cause hyperplasia of endometrium, which is not an atypical hyperplasia. They cause typical hyperplasia. And then you'll have to wait for two cycles at least for that to get back to normal. If that happens, which means they're interfering with endometrial blood flow as well. So no, I would not really go for a medical management unless there's some robust data.
Thank you. Thank you.
Any more
We
questions?
still have 10 minutes.
So I think the message is very clear. So forget about right or left. Just go straight, focused, either surgical intervention or no intervention for the fibroids which are in the myometrium, not distorting the cavity. For cavity distorting, intramural fibroids, type 0, 1, and also for type 2, it's better to remove them. Hysteroscopically is the best option. And if you are not comfortable with hysteroscopy for the type 2 fibroids, then laparoscopy, but it is a tedious job. So better to attain proficiency through hysteroscopic surgeries. So that comes out wonderful. You can do 2-stage surgeries also. So no medication. So thank you, Dr. Bhaskar. Any more? Do we have another speaker?
No.
Okay.
That's why I said we have 10.